Okay, so PEDS is divided into like 70 pages, I think, right? Is that what you said? So it's a pretty long chapter, but a lot of it is pretty repetitive as long as you know medical assessment and trauma assessment. So we're not going to go as in detail with that because you guys should already know that. So what we're going to do is for pediatrics, we're going to go over the differences between how we assess an adult and a child. So just something to know as an EMT, trauma is the leading cause of death in children, with motor vehicle accidents being one of the top reasons for death in children. A lot of the times a child has respiratory issues that can lead to more complications and death. So usually with a child, there's not as much cardiac issues that are due to just the cardiac system. It's usually a respiratory system that leads into cardiac issues. So we're going to be focusing a lot on respiratory issues that are in children and how to treat that, which should be around the same as we treat an adult, right, with respiratory issues. So on the National Registry, you're going to see different age groups in your questions. So it may ask you, a child in the school age range, or an adolescent approaches you, or this and that. So you really have to know the ages, because it really is, whenever it comes to vital signs and things like that, there's a different range for every age. So newborns and infants, birth to a year, toddlers 1 to 3, preschool is 3 to 6, and school age is 6 to 12. Adolescents 12 to 18, but a lot of the times, like for example, when we put an oxygen mask or AED pads, sometimes we may have to use an adult dosage or an adult mask. So for adolescents, sometimes we don't use child measurements. Also, an important thing to note is the way that we present ourselves with an adult is going to be a lot different than with a child. We're going to have to be a lot more nicer. You guys, I mean, you remember whenever you were a kid, you were always scared of going to the doctor or seeing this very big authoritative figure. So being really aware of that. A lot of you guys still have worked with kids before, so you know how that is. So just keep that in mind whenever you're dealing with smaller children. Don't use big words. Try to, talk more simple. Don't use any words such as, I'm going to take your blood pressure, because they usually, when they hear the word take, they think you're going to take something away, so they don't know what that means. So instead, tell them, oh, I have this balloon here that I'm going to put around your arm, or try to use like simple language with them to make it more fun and engaging. So anatomical and physiological differences. So in a child, they're going to have a larger proportion head. So that can lead to some issues such as the decrease in, temperature regulation. So a lot of children, they lose a lot of heat through their head or through their skin. They also have a larger skin surface area. So they can also dehydrate easily because more water is able to leave their body. Also, heart rate and respiratory rate is going to be elevated in a child. On here it says, for example, in a newborn, their heart rate is 140 and respiratory is 40 a minute. For an adult, what is it? Respiratory and heart rate. 12 to 20 for respiratory rate, and then 60 to 100 for heart rate. So just keep that in mind. Don't be alarmed if you see a really high pulse. Also, another thing is that whenever you're taking vitals for a child, they may be scared. So if you see a really elevated pulse, don't be alarmed. It's usually, you're usually able to see whether or not they're nervous, so keep that in mind. I remember when I was a kid and I would go to the doctor and the doctor would listen to my heart, he would know that I was nervous because I was always scared of going to the doctor as a kid, and so don't be alarmed, like I said. Another thing with their airway, so a child's airway is a lot more flexible. So whenever a child's laying down, it's a really good idea for you to put like a towel underneath their back, because sometimes even if you hyperextend their neck, it may close off the airway just because it's so flexible. So yeah, like I said, with the flexibility of the airway, not only that, but the tongue is proportionately larger, so it can it can obstruct the airway. So we really have to make sure to put that towel right underneath the shoulders, like in this picture. Also, whenever we're doing head tilt chin lift or jaw thrust maneuver on a child, be very careful with the area underneath their chin, this soft spot right here. If you guys press on it, you'll notice that you kind of feel like your airway's closing up a little, right? A little bit. So with a child, it's even more enhanced. So make sure that whenever you're holding their airway, you're not putting too much pressure on this area right here. Also, for infants, they're nasal breathers, so they'll breathe with their nose. As with children, they're abdominal breathers, so you'll see a lot of abdominal movement while they're breathing. The epiglottis, what's the epiglottis? Yeah, it covers your airway, right? Prevents you from choking. So it's positioned a lot higher in a child, and we'll see some issues that this can cause with children when we talk more about diseases and illnesses. Also, this word pliable, it means flexible. You'll see this word sometimes in your tests and stuff, so just remember that. So with a infant, we talked about this last time about the fontanelles. They have an anterior and posterior fontanelle. The posterior one closes first, and or goes away first, and then the front anterior one remains there until about 1 year of age. So avoid handling those. Be very careful with the head. Always support the head of a child. Like we said before, put a towel underneath the child's shoulders to keep their airway open. So for the chest and lungs, their ribs are a lot more flexible. There's a higher proportion of cartilage to bone in a child. So whenever you're assessing a child and this is a trauma patient, sometimes there can be a lot more organ damage and not as much rib fracture. So even though the rib fracture, you know how sometimes it can cause punctures in organs and stuff, you won't see this in children as much because they're very good at bending, but you will see some organ damage as well. So another thing is that in an infant, the liver and the spleen are a lot more exposed because of this, and so you'll see a higher chance of injuries in those areas. Also, you can see in the picture that the ribs are a lot more horizontal. So this is why you see a lot of chest breathing in children, or abdominal breathing. So respiratory system and cardiovascular system, like we talked about before, it's going to be increased. But in bradycardia is going to be a late response in children that are hypoxic, but it's an early response in newborns. So whatever I have highlighted is like the important part of it. Don't feel the need to like write everything down, but yeah. And like I said before about the liver and the spleen, it's going to be less protected by the ribs. The extremities, so whenever a child breaks a bone, usually in the extremities, since there's a higher proportion of cartilage to bone, it's going to bend more. And so this bending is going to, whenever it snaps, it's going to cause this green stick fracture, so it's going to be kind of like a splinting. So you'll see this a lot in children that have fractures or broken bones and stuff. So it's called green stick fractures. I would really remember this. I remember seeing this a lot in pediatrics. Everything I've highlighted is like what I saw most common in test questions and stuff, so this should be a little helpful. Metabolic rate, so children have a higher metabolism, faster metabolism, and so you're going to see that they're going to have a higher demand for glucose and oxygen. Their liver is not as mature as an adult, so what does the liver do with glucose? What does it do with it? The liver. It stores glucose as glycogen, right? Do you guys remember that? No? Yeah? Okay, so in children, the liver, since it's not as mature, it's going to break down as much glucose as it can to be able to help meet those high demands of metabolism. So they can also develop hypoglycemia a lot quicker because of that too. And then, like we said before about the skin, just because there's that higher surface area, they're going to lose more fluid, increased risk of hypothermia. A lot of heat can be released through the skin. Okay, so now with patient assessment. So like we said before, we really want to be as calm, as nice to the child as possible. Whenever you're approaching a child, don't hover over them. Try to get to their level, so usually like at your knees or sit down next to them, but make sure you're at eye level. This just helps them feel more calm, feel like you're not overpowering them and threatening to them. Don't lie to them if let's say you're splinting a child. Don't lie to them and say that it's not going to hurt, because we all know that that's definitely going to cause some pain. So if they ask you, be like, yes, but we're going to help you feel better. So also another thing is don't give false hope to the patient or the mother. If you know that this is a serious issue, don't tell her that, oh, he's going to be okay or she's going to be okay. Just I always use the word, we're trying our best, and we're hopeful. So don't tell her, yeah, he's going to be just fine or anything. Also with the child, if he's alone, make sure you tell them that you're going to call the parents, because that's usually the first person that they're going to look for is, oh, where's my mom, where's my dad? So call the parents, and then of course tell them that they're coming or that you already notified them. And then scene size up, as usual, we're not going to talk about that because you guys already know about scene size up. So with patient assessment, the most important thing, I think, out of all of it is this triangle. It's called the Pediatric Assessment Triangle, sorry. And so each corner is going to be a different topic like this. We'll talk about it here. The top corner is going to be appearance. So right when you approach a child, a lot of the times they're not going to let us like touch them or use a lot of equipment, so we really have to evaluate it from the moment we walk in or the moment we see the child. So this is going to help us gather as much information as we can just by visualizing the child there. So appearance, we're going to notice any muscle tone that they're having, any slouching, if they seem weak, things like that. Their activity, so are they looking around, are they just staring off into space? Are they crying weakly, like for an infant, are they weakly crying, or are they crying loudly? So this is pretty much assessing their level of consciousness also. So with workup breathing, which is the other point of the triangle, we're going to assess their if they have any abnormal sounds, if they're in a posture that would signify that they're having trouble breathing, like the tripod position. You guys know how that looks like, right? Mm-hmm. Yeah, so they're pretty much like this, hands on their knees. And then any usage of extra muscles in their body, like retraction. So I'll show you guys a video of how that looks like. Nasal flaring, wherever the nares are kind of big, or they look like they're bobbing their head, they look like they're sniffing around. All of these are going to signify that they're having some trouble breathing. So I'm going to show you guys what retractions look like. But it's pretty much the child using the diaphragm and any last muscle that they have in their body to try to breathe. So this is a very serious and sort of like a later stage of difficulty breathing. So I'll show you guys that. So with circulation to the skin, pallor is just paleness. So this is a very good indication of whether or not they're getting enough oxygen circulating through their blood. So modeling is this. I'll just turn the lights down so you can see it. Modeling is pretty much going to be like these little like splotches of pink. Sometimes it can be purple depending on their oxygen saturation. And then petechiae is these little, it kind of looks like little bruises underneath the skin. So all of this pretty much lets us know that they're not having enough oxygen in their system. And then I'll show you guys this patient assessment video, or pediatric assessment triangle video. They explain it really well on how we do this whenever we're with a child. So.
Of pediatric patients. So what are we talking about when we look at the pediatric assessment triangle? First of all, it's something you're going to use in your initial assessment, and it's easy to use. It's before you even get to the patient. It's non-invasive. You don't even actually touch the patient when using the pediatric assessment triangle, and that's one of the things that makes it so amazingly valuable for assessing pediatric patients, especially those very young patients who have a lot of stranger anxiety as part of their normal development. It's non-threatening because you can do it from a distance, from across the room, without ever approaching these patients, and it's really easy to do. Now, I'm serious, it really is. The pediatric assessment triangle is based on you using 3 variables to determine whether you have a sick or not sick patient. And by sick or not sick, we really mean critical or not critical. Is this a patient that you're going to be really loading and running with, or is this somebody you can stay and play with, that old adage? But in pediatric assessment triangle terms, it's sick or not sick. The 3 variables are appearance, work of breathing, and circulation. And these are the 3 things you can actually assess very well without ever getting too awful close to the patient and before you start using your stethoscope or actually hands-on inspecting patient injuries. So let's look at appearance first of all. Appearance uses the acronym TICKLES, and TICKLES refers to tone, interactiveness, consolability, look or gaze, and speech or cry. And these are the things you can look at from across the room. You're looking at their appearance and their general interacting with the environment, their tone. You know, how are they responding to their providers? If they're sitting with their mother, and this comes to consolability, they're interacting with their environment. They notice you when you walk into the room. Are they easily consoled? Is mom able to calm them down? When they look at you, does their gaze seem vacant? Are they actually making eye contact and appear to be looking at differences around the room? You know, in a very young child, in a 9-month-old, 12-month-old, toddler, you know, you walk in the room with all of your equipment, they are going to pay attention to you. And if they're not, that's an indication that something's wrong. Also, their speech or their cry. Are they using appropriate words for their age? Is their cry extreme and seems pained and, again, inconsolable? These are things you can look at. What about work of breathing? Well, work of breathing is something else you can look at across the room. You can watch their rate of breathing. You can see what they're doing. Is their rate very, very fast? Even in pediatric patients, too fast breathing is a sign of problems. What's their positioning? Are they tripoding? You know, in a young asthmatic patient, are they having to sit upright? Are they supporting their shoulders and trying to expand the rib cage by propping forward on their arms? Do you visualize retractions, suprasternal retractions, retractions if their shirt's off, retractions in the intercostal spaces or along the clavicles? You can see that. Nasal flaring, anxiety while they're breathing. Are they very anxious and upset and seem like they can't catch their breath? You can see all this when you enter the room. Finally, circulation. Circulation looks at just your general patient color, things like cyanosis. Are they pale in color, ashen, or mottled? These are the things you're going to be looking for in these patients to see if there is indeed the onset of shock occurring. Remember, pediatric patients plateau and maintain their compensatory mechanisms for a long time. And when they do that, the problem is that when they get to the inability to compensate stage, they crash very rapidly. Rather than that slow downward slope you see in adults, you actually see a straight line and then a cliff in that graph. And we really want to make sure we get a head start on any signs of shock. And you can see that when you look at their skin color. So let's review real quick. You want to assess these patients when you come into the room. You can look at them as you walk up to them and do this review very quickly. You can actually look at all three aspects. You're going to be looking at their appearance, how they interact with their environment. Are they consolable? Is their cry extreme? Do they use appropriate speech for their age? These kind of things. How hard are they breathing? What's their rate? Are they working hard? Are they tripoding, using some other position to compensate? Are they very anxious? And finally, circulation. We're looking here at their color, their skin color. Are they cyanotic? Are they pale or mottled? Or in dark-skinned persons, ashen in appearance. These things can all lead you to believe and determine whether this child is sick or not sick. And that is the purpose of the pediatric assessment triangle. You'll find more information like this over at medicast.com and, of course, in the Medicast Extra program that's available for those that subscribe as well. References are available as always. You'll find links on the website, and you can also follow these links here.
Okay, so does that make sense? Yes. Yeah, okay, cool. So compensated shock, so this is whenever the blood volume is low, so then the body is able to compensate for this by increasing the heart rate and constricting the blood vessels. Decompensated shock is whenever the body isn't able to compensate for this, so they're not able to maintain enough perfusion, oxygen, and blood volume in the body. So these terms are really important. So for pediatric advanced life support, so pretty much if the heart rate falls below 60 and the child is having either they're apneic or the breathing rate is pretty low, so below normal, gasping, they're snoring or showing any signs that they're not getting enough oxygen, then we're going to want to do the pediatric advanced life support, so pretty much CPR. And for CPR, how do you, what's the difference between adult and child CPR?
If it's 1 or 2, it's the same. Like if it's 2, it's 15 to 2.
Yeah, so it's 30 to 2 if you're alone, if you're with a partner. 15 to 2, you're not going to want to, if this is a small child, you're going to use one hand. If it's a larger child, you use 2 hands, right? You're going to use a child mask, which you guys have worked with that, right? You guys have seen that, the child mask, to deliver breaths. And also, I'm not sure if he has one, but it's a lot more, the volume of air that you're giving is a lot less, right? what's the amount? Because for adult it's 500, and then for child, what is it? It's just half, 250.
250?
Yeah.
Oh.
Okay, so what is not a component that is assessed in the pediatric assessment triangle? A, B, C, or D?
B.
Yeah, B. Okay, so for level of consciousness, so like we usually do with patient assessment, and like we talked about before, we want to see that a child is alert, that they know, you know, where they are, that they're looking around, that they're engaged. But whenever a infant is unconscious, you know how we usually do the sternal rub, or we usually pat on the person's back really hard. For an infant, don't shake the child. This is just obvious. And then gently tap them. We don't want to hurt the infant, so this should be a little common sense, but. So whenever we're assessing the airway, like we said before, put a towel underneath, under the head or on the shoulders. And we're really going to want to try to use an OPA as much as we can. Try to not use an NPA because children usually, or some of them, have inflamed adenoids, which we'll talk about that a little bit more later, but if you put an NPA in, it can cause excessive bleeding if they are inflamed. But I'll show you guys a picture of where they're located, that way you guys can know, but just know that it's located in like the nasal passage. Rapid breathing, so for an infant, it's going to be 25 to 30 a minute in an infant. Our normal breathing rate's 25 to 30, and in a child 15 to 30. So just know these rates. It's going to be a lot more elevated in an infant. So these are just some causes of rapid breathing, which most of these you guys know, so we can skip that. For noisy breathing, if they're coughing, gagging, gasping, this is going to mean that they've aspirated a foreign body or there's something blocking their airway. Crackles is going to mean that there's fluid in the alveoli, and then wheezing is going to mean that the bronchioles are narrowed. And whenever we're auscultating for lung sounds, we're going to use the mid-axillary line here. Stridor is just a severe upway obstruction. You guys have heard it on Steve, right? It's like a higher pitched sound. Diminished breathing usually means that the lung isn't inflating. And then after we go over this PowerPoint, I'm going to show you guys this website where you can practice hearing different lung sounds, because I don't know about you guys, but they all kind of sound the same for me, except obviously like stridor, but like for example rails and crackles usually are like the same. I think they said that for rails, if you get a piece of your hair and you kind of like put it near your ear, that's kind of how rails should sound like. But this website will definitely help you guys know the differences in sounds of the lungs. So for pulse, for an adult and an older child, you're going to take radial, right, if they're conscious. If they're unconscious, what do you do with the child and an adult? What pulse do you usually take?
Carotid.
Carotid, yes. And then for an infant, brachial pulse. Capillary refill should be less than 2 seconds. Blood pressure, you know, it's going to be a lot lower in children, right? So expect that. Whenever we're assessing the central pulse, we're going to use a femoral for an infant, and then for a child, we're going to use, that should not say radial, it should say carotid. Sorry. So carotid in child. All this is pretty much review, right? You guys know this. Okay, so like we said before, in a child, their respiratory system and their breathing rate, perfusion of oxygen is going to be really important. So all our priority patients that are going to require transport are going to be in respiratory distress, failure, arrest, and they're going to have poor perfusion. And we're going to talk about the differences between respiratory distress, failure, and arrest. But before that, we're going to talk about a little bit about patient assessment. So whenever we're doing our assessment, you know, we take their blood pressure, we look for pupil constriction whenever we use the flashlight. We want to get the child as in a way involved as we can, but not too involved. So for example, they'll see all these scary instruments, so try to have them a little bit more engaged by telling them, oh, do you want to listen to your own heart, or do you want to, like for example in this picture they have a teddy bear where they put an oxygen mask on it, so this will help the child kind of feel less scared by all these scary instruments. But with younger patients, especially like toddlers and infants, instead of doing the head-to-toe assessment starting from the head and ending at the toes, we're going to do a toe-to-head assessment. This just makes it a lot less scarier for them until they build our trust. And if we start up here with the light, it can be a lot more frightening, so just remember that. And then when we're assessing for pain, in OPQRST and sample, we ask, from 1 to 10, how bad is your pain? For a child, they can't really process that, so just use the little smiley faces, like, oh, how's your pain feeling? How is it making you feel? And usually they'll tell you, like, 7 to 9 or something. So remember to use this. Oh, another thing, whenever you're asking questions, don't give them, or don't allow them to say like yes or no. Kind of give them options, like, oh, do you want to do this instead of this, or like, what do you want to do? Give them a little bit more power in it, as long as it's the correct or the appropriate action that you have to take to make sure that they're healthy, right? We already talked about all of this. Oh, also, whenever the parent is involved, if that they're taking vital signs, if the child wants to sit on the parent's lap, they're allowed to, unless they're unconscious. But we'll talk about unconscious children in a bit. Okay. So early respiratory distress. So this is going to be the child using those accessory muscles, flared nostrils, stridor, grunting. Decompensated respiratory failure is going to be whenever we start seeing everything we saw here in respiratory distress, but cyanosis. So we're going to see increase in capillary refill. They're going to start, they're going to have like this weird gaze. They're going to be less conscious. And then respiratory arrest, this is whenever the breathing rate is below 10, or they're gasping, they're having, or they're apneic, they're not breathing. Partial airway obstruction, so we want the patient to, like we said before, whenever they're choking, but they're still making noise, we want them to cough as much as possible. Administer oxygen. Let them position themselves in whatever way they want, where they're more comfortable. Complete airway obstruction, this is where we're going to do the abdominal thrust, so they're not talking, their airway's completely obstructed. So with the child, again, we already talked about this whenever we were doing CPR, the abdominal thrust. With a infant, you're going to do the compressions to slaps on the back. I forgot what they're called. Huh? 5. So I'm going to ask one of you guys to show us how to do this. Because, like we said before, in an infant, you really have to be careful about the head, right? So who wants to demonstrate how to do this?
Trinity last year, she was like throwing the babies still. Can you demonstrate it first?
You just want me to demonstrate it? Okay. So if you have a chair, I think it's better to do it on a chair, but if not, usually have like the legs right here between your arm, and then you're going to do 1. Make sure that you're supporting the head, so I'm holding the baby's face right here. So 1, 2, this baby's so okay. 1, 2, 3, 4, 5. Flip it over. 1, 2, 3, 4, 5. And then just keep doing this motion here, making sure that you're supporting the head. So yeah. And it's 5 and 5. And then if the child or the infant becomes unconscious, we're going to do CPR. These are the ratios. Infant, 15 to 2, child and adult are the same. Remember to not do the blind finger sweeps. You don't want to get your fingers chopped off. For suctioning, with adults it was 10 to 15 seconds, right? But with a child, it's going to be 3 to 5 seconds. Why is it that you don't want to suction for too long? Do you guys remember? What? Yeah, the vagal response, right? So if you suction for too long, the vagal response will cause them to have their blood pressure to decrease, and that can be dangerous. So what I was talking about before, we want to stick to an OPA as much as possible because most children have the adenoids, and I actually had this problem when I was a child. Mine were inflamed, and so I had to get mine removed. But if you use an NPA, you can irritate this, and it can cause bleeding. So if possible, use OPA. And then, like we said before, since the tongue is so proportionately larger, you may want to use a tongue depressor to be able to insert an OPA. Make sure to use the correct mask size, adult, child, infant. Whenever we were doing the skills last week, I noticed that some of you guys weren't holding the seal as well, but just remember that it's going to be the EC method. So if we have, what's this guy's name? Does he have a name? No. So these 3 fingers are going to help us with the head tilt chin lift, and then the C is going to help us keep that seal. So just make sure to do that whenever you're giving ventilations. So like this. Some of you guys are going like, I don't know, just like this, but the best seal is going to be the EC method. Ventilate 20 to 25 times a minute. If sometimes you may see regurgitation or gastric, what's it called? Gastric distension. And so we want to put pressure on the cricoid right here, which is underneath the Adam's apple. You guys know this. Also, if the child doesn't tolerate a mask, you want to do the blow-by technique, especially with infants. Okay, questions? Pretty easy, right?